Thank you. So in an effort to contain spending, healthcare policy is continuing to move towards value-based payment. And for surgeons, that means that we are ever increasing responsibility for our patients' perioperative resource utilization, both in our surgery clinics and outside. Non-urgent emergency department visits are a substantial source of economic burden to the health system. We've seen in medical patients that 20% of visits to the ED are for non-urgent reasons and potentially be treated in less acute settings such as urgent care centers. If those patients were shifted to these centers, it's been estimated that savings would be a little over $4 billion per year. In bariatric surgery, post-operative ED utilization is also a significant source of spending, and studies have shown that upwards to 15% of patients will visit the ED at least once within 90 days of surgery. 50 to 75% of these visits do not result in readmission and therefore could potentially be managed in lower acuity settings. Now, while the decision of who to treat in these settings and when they should go is unclear, we wanted to look at the potential financial benefit of shifting patients from emergency department visits to urgent care centers. To do this, we looked at patients 18 years and older undergoing primary sleeve gastrectomy or Roux-en-Y gastric bypass. We utilized the Michigan Bariatric Surgery Collaborative, which is a statewide collaborative of 45 hospitals in the state of Michigan, which collects clinical data on about 95% of all patients undergoing bariatric surgery, as well as the Michigan Value Collaborative, which is a 75-hospital statewide consortium, which collects payment data. Which collects payment data for Medicare fee-for-service beneficiaries, as well as Blue Cross Blue Shield of Michigan PPO patients. We first wanted to assess the magnitude of, I'm not quite sure. Our primary outcome was price standardized spending, both for potentially avoidable ED visits and urgent care center encounters. And for this talk, we defined potentially avoidable ED visits as those not resulting in inpatient admission. We first wanted to get a sense of the magnitude of potentially avoidable ED visits in the state of Michigan, and so we retrospectively looked at our entire collaborative. So seen here on the x-axis is each year of our collaborative and the annual rates for ED visits in red and readmissions in blue, and the gap between those can be assessed as the potentially avoidable ED visits. And you can see that there hasn't been a significant improvement in closing that gap. For more granular data, we looked at visits between October 2011 and April 2017. And for those 36,000 patients, ED visits were 8.4% with readmission rates of 4.2%. And so roughly 50% of our visits could be defined as potentially avoidable. Next, to look at spending, we looked at patients between 2011 and 2017 and identified in our MVC database all patients that had a bariatric operation, and then selected those that had claims data for an emergency department visit or an urgent care visit. Those encounters were then matched to our MBSC database based off patient characteristics, hospital factors, and surgeon characteristics. And we were ultimately able to match 920 encounters. Those ED visits that resulted in readmission were excluded, and we ultimately ended up with 388 potentially avoidable ED visits and 110 urgent care center encounters. We next looked at patient characteristics and outcomes of the patients who went to emergency department visits, went to the emergency department and urgent care to see if there's any statistical differences. I'm not sure why it's pressing on its own. Looking at patient characteristics, the only significant difference we saw is that patients who went to the ED had a higher rate of having undergone a sleeve gastrectomy compared to those that went to an urgent care. But there was no difference in other patient demographics, social constraints such as education level, social support, or income, or in number of comorbidities. When we looked at complications, we did see that patients who went to the ED and were discharged had a higher likelihood of having a complication, but that there was no difference in serious outcomes or mortality. Next, we looked at spending. Since seeing that these two groups were essentially similar, we wanted to see if there would be benefit in shifting them. Seen here on the x-axis are potentially avoidable ED visits, with each separate bar representing an individual episode, and on the y-axis, the average spending for that episode. This is the interquartile range of visits, and you can see that for the interquartile, spending ranged from roughly $1,000 to $5,000. And when we looked at our entire cohort, the average spending for an emergency department visit not resulting in admission was roughly $4,400 with a median of $2,000. In comparison, when we looked at those that went to the urgent care, the interquartile range spanned from roughly $75 to $300, with average spending of $108 and median spending of $99. Overall, shifting a patient from an emergency department visit not resulting in admission to an urgent care center could save, on average, $4,300. If we extrapolate that number to our cohort in the state of Michigan, this would result in savings of just a little over $6.5 million over a 6-year period. And when we extrapolate that to the average number of primary sleeve gastrectomies and Roux-en-Y gastrectomies performed each year in the United States, that would result in roughly $30 million in savings. Overall, in our cohort, roughly 8% of patients visited the ED postoperatively, and 50% of those patients had an ED visit that did not result in an admission and potentially could be managed in a lower acuity setting. Shifting these patients to urgent cares would result in significant savings and could serve as a template for attempting to reduce costs in our perioperative period. Overall, as we continue to move towards value-based payment, both for healthcare systems and providers, it's important that we're cognizant of not only the quality, but also of the cost of care that we're providing, and that we focus not only on postoperative readmissions, but also overall ED utilization. In order for a strategy like this to be feasible, a lot of efforts toward further patient education will be needed, both on improving their ability to assess the severity of their own symptoms, knowing when and how to contact providers, and also in order to improve the appropriateness of their care center selection. And finally, as our overall goal is always to provide high quality care, further understanding of both the quality of care provided in urgent care centers, as well as providers' attitude and competency to care for our bariatric surgery patients will be needed. Thank you.